Hello, everyone. Thank you for joining Career Search today. I'm Paula. I'm your host for this webinar. Today, we're going to discuss intimate partner violence, or IPV, which is a public health problem of epic proportions. IPV contributes to injuries, chronic health issues, and high-risk behaviors. Screening for all patients can improve health and decrease the risk for violence. EMS clinicians have a unique, safe, and private office space in which to screen for IPV. This presentation today will provide the EMS provider with screening tools and evidence-based interventions. I'm happy to introduce you to our presenter today, Melody Kolmetz. She has been an EMS provider since 1991, a New York State paramedic since 2012, New York State certified instructor coordinator since 2011, and a nationally certified PA since 1995. Melody currently provides clinical care as part of the Rochester Regional Health Mobile Surgical Services team. That's a very long name. And occupational medicine school physician services at Northern Star Medical, where she provides care for several of the local fire departments and EMS agencies. She is also currently Director of Didactic Education and a principal faculty member in the Developing Physician Assistant program in the School of Health Sciences and Human Performance at Ithaca College. Melody will be taking questions throughout the presentation today, so be sure to share those in the chat. You can type them, but if you want to ask a question live, make sure you include that live word at the beginning of your question so I can know to unmute your mic. Also, the presentation has been attached as a handout. It's a PDF, so feel free to download that. If you can't for some reason, just send me a message in the chat and the question box, and I will make sure to get it to you. With all that said, Melody, the floor is yours.
Thank you so much. I much appreciate that kind introduction. And thank you and shout out to the folks that are joining us this morning or this afternoon, depending on where you are. I have to say, this is a topic that is near and dear to my heart, and it has been for a long time. And given I put the talk together before the Gabby Petito case came about. But I think that that case and many of the other cases that have come to light in the last couple of months really highlight the need for more education and stronger discussion about IPV. So I'm happy that you took some time out of your busy days to share some time with us and hopefully stretch your brains a little bit and learn a little bit more about how we can do better. I think that long introduction, to sum it up, I've been doing medicine for a long time, and I do a whole bunch of different things because I like to continue learning and improving my profession. So without further ado, let's get into some learning. As she said, I am trained both as a PA and as a paramedic. I keep saying I'm going to escape EMS, and then I have a great encounter with a patient where I realize, no, I still bring so much to that table, and there's something so special about that one-on-one interaction that you have with your patient, particularly in that private space, that brave, safe space in the back of the ambulance. So I enjoy providing some knowledge about how the system works and the resources that are there. And I really, really appreciate the opportunity to share that and model good behavior for the newer providers that I have a privilege of working with. So we gotta begin an educational session with some information about what our goals or outcomes are. So I would hope that by the end of this session, you'll be able to recognize some of the common signs and symptoms of intimate partner violence. And I expect that some of those signs and symptoms might be new to you or might be different than ones that you have heard about or learned about in the past. The second outcome, I hope that we can demonstrate some non-judgmental communication skills when we are screening for IPV, because as I alluded to before, we really are in a unique situation where we have the opportunity to have some of these crucial, difficult conversations. And lastly, if we identify folks that are at risk of IPV, we need to have resources to provide those patients. So community resources or just action plans. How can we help these folks and get them what they need to be safe if their situation progresses. So I always begin these difficult conversations with a disclaimer. There may be some tough topics that we're going to talk about. There may be some things that are bothersome to you, and they may bring up some past traumas. So be aware of that. And if you need to turn the microphone off or walk away for a little bit, that's fine. Please feel free to do so. Self-care is of the utmost importance. We're going to begin with a case study. All right, Joy is a 25-year-old female. She met her husband 6 years ago, and they got married 2 years ago. He calls her frequently during the day to check in. One day she notices her computer isn't working right, and the repair guy tells her that it has spyware on it. A few months later, she notices money missing from her checking account, and her husband tells her the bank made an error, the bank screwed it up. She's often invited to go out with her friends, but her husband requests that she stay home for date night. I am curious to know what you think of this situation, so please feel free, throw some comments in the chat. What do you think about this? Typical, atypical, what do you think? What do you think? What do you think? Concerning, not concerning? All right. We'll come back to that case as we move through here. So let's define intimate partner violence. It's a pattern of behavior that one person in an intimate partner relationship uses against the other person in the relationship to try and establish and maintain power and control. And that intimate partner relationship can include a spouse, a romantic partner who you live with, fiancés, dating partners, anybody who you have an intimate partner relationship with. So this is different than child abuse, elder abuse. Though those folks have close relationships, there is not a specific intimate partner relationship. You'll notice that there's probably some overlaps and crossovers there, but it's not the same. Yes, and I appreciate whoever said definitely concerning, very controlling. It's easy to write those individual things off though when they happen one at a time. It's easy to convince yourself that those things happen just because the partner cares about you. I love the history of medicine. I am sort of, I don't know, fascinated, I guess is a good word, by it. So whenever I'm researching a topic, I try to dig into the history of it a little bit. And it's interesting that there is some evidence that intimate partner violence existed or is documented as early as 750 BCE. And there's some documentation during Constantine the Great in 300 CE. But it's interesting that wife battering was not defined as an official crime until 1945. However, they didn't begin collecting data about the problem until the 1970s. And in the 1970s, the first shelter for battered women appeared, and the terms woman battering or domestic violence emerged. And this information comes from a paper from the Indiana Coalition Against Domestic Violence, which dates back to 1999, which is why it was called domestic violence. And they've worked to refine the title a little bit in the meantime, which is how we got to intimate partner violence. Domestic has some connotations that don't necessarily lend themselves to a true definition. So intimate partner is a little bit more specific. What are some consequences of IPV? Certainly the physical maladies you would think of from physical abuse. So cuts, bruises, broken bones, those sorts of things. But there's a ton of mental issues and mental disabilities that come along with IPV, from depression to anxiety to post-traumatic stress disorder, to even some of those areas where physical crosses over with mental when we're talking about traumatic brain injuries, things of those sorts. Unintended pregnancies certainly can be a consequence of IPV, as can sexually transmitted infections. In general, folks who have been victims of IPV don't feel safe. They don't feel safe at home. They don't feel safe in the workplace. And that recurrent trauma certainly propagates that feeling of lack of safety, if you will. There is documented lack of work productivity. Folks who are victims of intimate partner violence have lower socioeconomic status. They miss work. They are unable to maintain higher paying jobs, etc. They're unable to complete educational requirements that would benefit them in achieving higher paying jobs. And IPV as a whole is a significant burden on society. Greater than 8.3 million healthcare dollars each year go towards paying for IPV. It's greater than 8.3 million. That's a lot of money. And I must say, that includes documented cases of IPV. How many other injuries and illnesses are there out there that are directly caused by IPV but aren't documented as such because people are ashamed and don't want to, or maybe they're in danger if they admit that these issues are related to IPV. So 8.3 million is only what we know. What we don't is probably significantly higher. All right, Paula, can you go ahead and share the results of that first poll? I'm interested to see how things come out.
Melody, I don't know if you're seeing the results. I know our audience is, so I'm just going to read them out loud just in case you can't see
Yeah, I
them.
don't see them, so yeah,
Okay,
please
that's
share them.
why. So, yes got 79% and no got 21%. And again, the question was, have you or someone you know been a victim of intimate partner violence?
That's about what I would have expected. Thank you all for participating in that poll. I would have guessed probably 75%, so we were pretty close. All right, let's talk about some risk factors here. Victims of IPV come from a variety of backgrounds, different ages, different religions, different ethnic and racial groups, different socioeconomic levels. We talked about we talked about it being a risk for having a lower socioeconomic status, but that does not mean that people with higher socioeconomic status don't have issues with IPV. Certainly people with various educational backgrounds, various sexual orientation, and there is no single profile of an abused woman, an abused man, or a perpetrator. We typically think about IPV as the woman is the victim and the male is the perpetrator, but that's not necessarily true. Men can be victims of intimate partner violence just as much as women can be. Risk factors of being a victim. Being a victim of child abuse or witnessing parental IPV is the single most significant risk factor. Folks under age 24 are at greater risk. There's not really great documentation of why that age 24 is critical, but to some degree it might have something to do with the frontal lobe of the brain not being fully formed before about the age of 24. People with low self-esteem are at greater risk. Folks who live in poverty, if you're not married, if you have young children in the home, that can create stressful situations which can contribute to IPV. Folks who have multiple sexual partners are at risk of IPV. Women who are pregnant are at greater risk of IPV, and women who are not pregnant and don't want to become pregnant are also at risk of IPV if the partner's wishes are different. If they were raised with violence at home, then again, that's a risk factor for intimate partner violence, being a victim. Ethnicity is another risk factor. There's a higher prevalence, incidence, and recurrence of IPV among African American and Hispanic couples compared with white couples. Immigrant women, women with disabilities, and the elderly are at greater risk. In families or relationships where alcohol use is a problem, folks with less education, or in living in specific communities or families where there's male dominant norms. And sometimes that relates to religion. Sometimes that relates to, again, that socioeconomic status. All right, so we talked a little bit about victims. Let's talk a little bit about perpetrators. They are usually somewhere between 26 and 35 years old. They can be labeled as hostile or unstable. Typically, when you talk with people in their workplace or even their other family members, they'll say, wow, he was always so angry. Interestingly, they have a low level of assertiveness. They're not good at standing up for themselves. And as a result, that makes a difference in terms of their need to sort of assert control over others. They do tend to have issues with impulsive behaviors, and as a result, they have some inability to regulate their aggression. So it stands to reason that they'll take that aggression out on folks who are closest to them, and that is their intimate partner. Risk factors for homicide. Abuse in a previous relationship. If they are thinking about leaving the abuser or leaving the situation, if they have been stalked, if they have been strangled. Strangulation is the most significant risk factor for homicide as a result of IPV. Certainly availability of handguns and other weapons. If there's been a change in the perpetrator's behavior, the victim has asserted themselves and the perpetrator has had some loss of control over the victim, or if there's barriers to help, they just can't obtain the assistance that they need. I have to say, thinking about this Gabby Petito case, when her body was discovered, I immediately thought, I bet I know how she died. And I was watching to see what the autopsy would show, and I was not at all surprised that the cause of death was determined to be strangulation, because as I just said, that is the biggest risk factor for homicide as a result of IPV. All right.
All right, so please feel free to answer the poll. The question is, have you or someone you know been a victim of homicide due to intimate partner violence?
So we talked about whether we know someone or whether we ourselves have been acquainted with someone who was a victim of IPV, but I would like to know how many of us have known someone who was killed as a result of IPV. We'll give it a little bit for everyone to answer. And when you're ready, Paula, please put up the results and let me know what they are.
Will do. We still have some people voting, so let's give them a couple more
Excellent,
seconds.
excellent, excellent.
All right, so sharing the results now. We have 82% saying no, 18% saying yes.
Wow, that's higher than I would have guessed. And I'm sorry for those people that said yes in the 18%. My sympathies to you and your loved one. I will say one of the reasons that this topic is near and dear to my heart is that I too have a family member who likely died as a result of IPV. I have an older cousin who was attempting to escape a violent marriage, and she disappeared almost 20 years ago and has never been found. So we can suspect, but we'll never know. All right, so let me get back to these slides here. They're not cooperating. All right, so stories from family members who were, their loved ones died of homicide. She couldn't escape him no matter where she moved. There was an increase in arguing after the partner told the partner that the marriage was over. Family members have commented about the extreme jealousy and the barriers that IPV victims encounter when they're trying to escape the situation or they're trying to get help. And those barriers can be put in place by the perpetrator. They can be some of those manipulative things that we saw in our case study. Isolation. No, you can't go out with your friends. Stay home with me. The justice system and the social and mental health organizations can always improve and recognize these situations. And it's sometimes the fact that it's not that they're not recognized, but they would have better outcomes if they were recognized earlier in the game. And that's where we come in as EMS providers. And that leads to the last thing. Barriers to healthcare providers don't know what to ask or are afraid to ask. And the title of this session was Go Beyond Checking the Box. So I'd like you to think about when you have yourself gone for a healthcare encounter in the intake process or the triage process. They ask you what you're there for and they get your vitals and then they go through those screening questions, which could certainly be helpful. Many places are doing screening questions for anxiety or screening questions for depression, but most places have added a screening question about intimate partner violence. And it might be something as simple as, do you feel safe at home? Or are you safe where you're living? But it's how the questions are asked. Sometimes it feels like people are just going through the motions and checking the box in order to say that it was done. And I can't imagine that victims of IPV would be very anxious to say, well, yeah, I have been a victim of IPV. So we have the opportunity to set the tone and have our patients open up to us because it really is a safe space where they can share these types of information with us if we open that door and let them do so. All right, patterns of IPV. People typically think about IPV being just physical abuse, and that's the first one that we'll talk about. It can be as simple as marking or branding, just putting bruises in certain places. It can be as severe as hitting, shoving, slapping, punching, restraining, as we talked about, choking or strangling, welts, lacerations, pulling hair or pulling hair out. So when I think about IPV, I think physical abuse is the first thing that comes to mind. But Emotional abuse might be the second. I think people are kind of tuned in to threatening or intimidation, jealousy, possessiveness, constant criticizing or demeaning, insulting, belittling the victim, making the victim have little self-worth, blaming the victim for things. It sort of leads to almost like an imposter syndrome type thing, where you end up questioning your own sanity and thinking that you somehow must have done something wrong. That emotional abuse can be extremely powerful. Sexual abuse is one that is not often talked about. Uh, Coercing the victim to have sex, making them watch pornography, uh, transmitting sexually transmitted diseases, demanding photography, sabotaging their birth control, as we talked about pregnancy or not wanting to be pregnant is a risk factor, and even go so far as using date rape drugs like Rohypnol. And that is a method of sexual abuse. Financial abuse is one that is not often recognized. Withholding money or withholding access to bank accounts or ATM cards or credit cards, ruining the victim's credit. Sometimes women don't even know, or men too, they don't even know that their credit has been ruined until they attempt to escape and they need to apply for an apartment or they need to buy a car only to find out that their credit score is in the tank because their partner has ruined it. They bought things, not paid things, etc. Some partners will actually take the partner's paycheck and not let them have access to it or give them an allowance. And some have issues with gambling and they have gambled away the family's money or savings. So that's a form of financial abuse as well. And sort of the latest addition to forms of abuse is technology abuse. Now, I happen to love technology. I'd say I'm a tech nerd, but that technology comes with risks and benefits. Technology allows perpetrators to track the location of victims very easily. Those tracking devices are very inexpensive. Some can even be placed on the victim's cell phone. It can demand check-ins. You have your phone available all the time, so it makes it super easy to check in and demand text messages, that sort of thing. It's easy to put spyware on phones and computers. Uh, Spoofing and pretending to be other people, certainly another method of technology abuse. Monitoring communications on social media or via text messages, via email, so many ways to monitor communications such that a victim might not have any safe method of communicating to their support system that they've been a victim of IPV. And the social media aspect of technology abuse is another whole session in and of itself. And the final one, legal abuse. And this is particularly apparent when there are children involved in the situation. So manipulation, constantly threatening to take custody of the children or file for full custody. Excessively filing motions in court where the victim has to defend. So that means they have to take time away from work, time away from their children. It costs money to defend themselves, even if they have free legal services. It's still time that they're going to miss from work, and that's affecting their paycheck and their bottom line. Often they'll use their parental rights to contact the victim. So even if there is legal prevention in place, they can still contact the victim under the auspices of parental rights. Or the last one here on the list, I have seen happen in the past, where the perpetrator actually makes excessive reports to Child Protective Services, and Child Protective Services is bound to investigate each and every one of those reports of abuse, but the victim has to continue participating in those investigations, which again takes time, takes energy, takes money. So that's a method of control as well.
All right, so we're
Yeah,
launching
yeah.
our Our next poll question is, when providing patient care, which of the following methods of control do you think is the easiest for EMS providers to discover? Emotional abuse,
Which one's the
physical abuse, sexual abuse, or technology abuse? And while people
which one's the
answer,
easiest
Melody,
one to see?
just wanted to read a comment also. Someone said have them deported, and that's for sure
Yeah,
another method of legal abuse.
100%, absolutely. And that's even more true, obviously, in areas where there are significant immigrant populations. I happen to live in upstate in Western New York, so there are a lot of farm migrant workers in my community, and I have seen that happen firsthand.
Yeah, pretty sad. We have just launched, just sharing the results from that question, and we got 87% of physical abuse, 13% of emotional abuse, and then 0% for both sexual abuse and technology abuse.
Very good, very good. Not surprising, you guys are smart, you figured it out. All right, let's talk about IPV in some specific populations. IPV is 2 to 4 times more frequent with respondents who identify as LGBTQ, who are either transgender or non-binary gender, multiracial, American Indian, Alaska Native, Black, Asian, Hispanic, or Latinx, or those who have disabilities are at greater risk of IPV. So when we think about risk factors or assessing our patients, we should be thinking about that when we're looking at the patient in front of us. Do they fall in any of these categories, in which case it is a risk factor and we need to be more attuned to the possibility. So pregnancy, as I alluded to before, is a huge risk factor. It is likely to escalate if IPV already exists and then the victim becomes pregnant. The IPV is going to escalate and the levels of violence will become more severe. IPV victims who are pregnant have a threefold risk of being murdered. That's a huge increase in risk. And they have a significantly increased risk of complications during that pregnancy because of the trauma of IPV. So think about that when you're seeing patients. Think about those risk factors and just try to tune up your antenna. Pay closer attention. Right? Health effects of IPV. It's not just the obvious physical effects of broken bones and bruises. Certainly injuries like that are common, but patients with chronic headaches or chronic insomnia, IPV has a connection to those things. Other types of chronic pain disorders. Patients with choking sensations. I learned this in my 5 years in working in gastroenterology. I would see patients come into the office and complain of trouble swallowing. And you would go through the whole workup and think, well, you have GERD, let's get an endoscopy. Oh, maybe you have achalasia, a muscle issue, so let's get a swallowing study. And when that stuff would all come back normal, I would be like, what's left? And I would have to think about what other things I could add to my differential. And after doing some investigation, I realized, IPV is a risk factor. So eventually I got smart and I would screen for IPV at the beginning of the workup instead of at the end after we did all those expensive tests. And holy cow, the number of times I got yes as an answer, I was absolutely blown away. Because again, I thought I was checking the box. Let's just take that off the differential. And I was shocked by how often that was positive. Folks with anxiety or hyperventilation, that can be related to IPV. As I alluded to, those sorts of GI symptoms, chest pain, back pain, pelvic pain, TBIs, like I talked about before, those non-fatal strangulation situations can still lead to loss of oxygen to the brain and some neurologic sequelae, unplanned pregnancies or complications, STIs, and Substance use disorders have a direct connection with IPV. Let's talk about kids who are witnesses to IPV. 1/3 of reported IPV cases involve at least one child witness. 1/3 of the children themselves experience physical abuse, and 15% of them experience sexual abuse at the hands of the offender. Kids who witness abuse are 3 times more likely to think about suicide and be told they have a substance abuse problem, 4 times more likely to experience child abuse, 4 times more likely to be told they have mental illness and attempt suicide, and 6 times more likely to be abused as an adult. So we owe it to our kids to protect them. And by protecting them, we're protecting society as a whole. Those kids that witness IPV are at risk of becoming a victim or a perpetrator. They exhibit aggressive behavior, disengagement, absence from school, depression, PTSD, poor self-image, and poor health issues because they can have those same health issues that we just talked about. So we've laid the groundwork. I think we would all agree that IPV is a problem, and oftentimes it's a silent problem. So how do we shed some light on it? How do we screen for it? It's a frequently told story. Oh, the relationship is new. There's some level of seduction and charm. Then we move on to isolation. We limit contact to family and friends, limit access to resources, and then it escalates to violence or threat of violence. There's weapons, there's physical assault, etc. As I alluded to before, there's some lack of awareness on the part of the practitioner, lack of education, or we're all tight on time. No one wants to open that Pandora's box because that will take time. Or we're uncertain of how to intervene. Okay, what do I do if that person says yes? Like, how do I fix it? Because we're all fixers, right? That's why we're in medicine. We want to help people. We want to fix things. Some of us have been traumatized ourselves, so we don't want to listen to others' painful, depressing issues. Or we have a fear of helplessness because we know that we can't fix or change the situation. Yeah. Or there's a time challenge. All right, Paula, you got a slide up, right? A poll?
So it's on right now.
All
The
right.
question is, how much training have you as an EMS provider had in IPV? And then we're asking our attendees to choose one between none, a little, a medium amount, or a lot. We have 71% of our audience voting. We have a little bit more. That number is increasing, and let's give them a couple more seconds. I think we
Yeah,
can
let's give
hear.
them a little time. I'm really curious to see the answer to this one.
All right, so we got 52% saying a little, 28% saying a medium amount, surprisingly 20% saying none, and more surprisingly 0% saying a lot.
That doesn't surprise me. It saddens me, but it doesn't surprise me. But now, after today, you are all going to be able to say, I have had some training in this, and that excites me, and it makes me happy because you'll have more tools in the toolbox to help your patients. All right, so let's teach you how you can screen. That's the piece here. It's important to know we are responsible for screening. And we as providers, like I said, we all want to fix things. I'm the first person that says, I want to fix this problem. But I've had to make peace with the fact that I can't fix things every single time. But I can understand the risk factors. I can screen. I can assess the level of danger. How great is the risk? And I can give appropriate and safe advice. Even if the victim is not in a position where they're ready, willing, and able to take that advice when they're standing in front of me, I have provided them with tools that they can use in the future. I can refer them to local agencies, and I can help them get help for their other family members at risk, particularly their kids. And I think that's one of the things that I found to be a barrier early on in my EMS career. Like, okay, you go to one of these calls, you would give them advice and say, well, you need to go to the shelter, or you need to go here, you need to go there. But I didn't understand that folks weren't ready or able to do that at that moment in time. It takes time and planning to escape these situations. So my expectations as the provider were unfair. So there are several validated screening tools for IPV. One is called the Abuse Assessment Screen. That's 5 questions. It's also available in Spanish. There's one that called the Danger Assessment. That's 15 items, and that one is specifically meant to assess danger of homicide. The HIT screen, hurt, insult, threaten, and scream. That one you may have seen before. And then there's the WAST, which is short. It's just 2 items. It does come in Spanish, and then there's an extended version that has 8 items. So I have selected the WAST because I think it's the easiest one to remember, and I think it has the most value in our situation as EMS providers, because oftentimes we're seeing patients that we don't have an established relationship with. We don't know their background. We don't know their backstory. Some of these other screenings, I think, lend themselves to more of a primary care or women's health setting where the provider knows the patient, knows their family, knows their situation. So I like the fact that this WAST screening opens with a simple question. In general, how would you describe your relationship with your partner? A lot of tension, some tension, no tension. Super easy. And how do you and your partner work out arguments? Is it difficult, some difficult, or not difficult? Easy answers, right? If someone answers option 1 or option 2 to either of those questions, so some tension or a lot of tension, some difficulty or great difficulty, then you go on and you ask the follow-up questions. Do arguments ever result in you feeling down or bad about yourself? Do arguments ever result in hitting, kicking, or pushing? Do you ever feel frightened by what your partner says or does? Has your partner ever abused you physically? Has your partner ever abused you emotionally? Has your partner ever abused you sexually? I think these are relatively easy questions to remember. So even if I don't have the cue card sitting right in front of me, I can remember physical abuse, hitting, kicking, pushing, emotional abuse. I'm frightened by what the partner says, physical stuff, emotional stuff, sexual abuse. I can remember those other questions that I need to ask. All right, I think we have another poll. Let's put it up.
So having seen the WASP screening questions, would you feel comfortable asking those questions when appropriate? Yes,
I'll go back.
no, or maybe. We're seeing a lot of yes, some maybes.
Good.
It's still
And maybe it wasn't fair of me to answer that question this early on in the game because I haven't told you about what you can do with a positive answer. So hopefully by the time we get to the end and I've provided you with some directions and some resources, folks will feel comfortable asking these questions.
I agree. The poll is closed now, so sharing the results, 58% said yes, 38% said maybe, and 4% said no.
Good. All right. So let's give you some tools. Once we screen, what do? The next step. If I have screened someone and I have determined that there is a significant risk, I need to immediately assess for risk of violence. So has physical violence happened more often or gotten worse in the last 6 months? Has your partner ever used a weapon or threatened you with a weapon? Has your partner tried to strangle you? Like I said, huge risk factor. Do you believe he or she could kill you? Has he or she ever beaten you when you were pregnant? Has he or she violently or is constantly jealous of you? If you say yes to at least 3 of those questions, that can indicate immediate danger of violence. And that deserves immediate intervention. And that immediate intervention could be a safety plan. It could be referral to a safe place to live. It could be a variety of different things. Let's talk about safety plans. Often victims stay because they hope that things will get better. Oftentimes victims deal with significant IPV situations 5 to 7 times before they finally get up the courage to leave. They're worried about disappointing their friends, their family, or their community. They have lack of resources to care for themselves or their children. It all comes down to Maslow's hierarchy of needs. We need a safe place to live. We need food. We need clothing. We need sleep. We need to meet those needs first. Maybe leaving is against their religious or cultural beliefs. As someone alluded to before, it could affect their immigration status. Or they believe that they need to stay in order to keep themselves or their children safe. Or they have tried to leave before and the behavior has escalated to the point where now they're really afraid of being hurt or killed. So they stay because they feel like they don't have any other option, or they feel like it's going to take them a long time to plan. So it's easy for us to say, just leave. And that is absolutely the wrong answer. It's a common belief that survivors can exercise control over their circumstances, but access to resources really directly affects their safety. So as I've alluded to, sometimes it takes planning to get there. And oftentimes our focus is on physical injury. It's on the bruises and the broken bones. We need to also focus on the mental and emotional effects, because it's not just physical. And sometimes we got to fix the mental and emotional stuff before we can get ready to leave. There's worries about housing and utilities and transportation and school expenses. If the victim isn't working, the partner might be the only one that's a source of income. Maybe they don't have transportation, so they're isolated. They may have had poor experiences in the past when the abuse has come to light. They're embarrassed, they're fearful of being deported, as someone referred to before. Or they grow up in a culture of violence and they don't even recognize that it's wrong. And like I talked about, Maslow's hierarchy of needs: breathing, food, water, shelter, clothing, sleep. Those physiologic needs need to be met first, even before the next level, as you see, which is safety and security. So key components of a safety plan: violence support services, access to healthcare, mental health care services, those basic needs, housing and employment in order to be successful. So talk with the patient, screen privately in a one-on-one situation, and assure confidentiality. Talk in a manner that's understandable, that you're comfortable with. Listen and provide non-judgmental and support. We do not need to solve the victim's problems. In fact, we can't solve their problems, and we are not going to be successful at convincing the victim to leave. That is the victim's decision only. We can't make them. We cannot make them go to the police or utilize the court system. We can, however, provide those resources. We don't need to ask a ton of detailed questions because that exposes the victim's trauma. We obtain that information and we're not going to do anything with that information. So don't dig deep into those tough questions. That's not our role. That's not our job. And don't make the victim talk about their feelings. Again, we're not trained psychotherapists, so those actions could cause more harm than good. Listening really is the key here. I love this mnemonic. I love mnemonics. So empathic listening, empower. Make time to properly document your findings. Provide information about IPV. Offer options and choices. Work with an abuse specialist. Encourage planning for safety and support. And refer to local services. So empower our victims of IPV. Listen, enhance safety, inquire about needs and concerns, validate that this truly is an issue, and provide support. I want to give you a little case. The reason that I suggested this topic was way back in August. I was working on the ambulance. I was called to a scene where there was concern about injuries from an altercation. Law enforcement was already on scene. The perpetrator was inside the house and was allegedly intoxicated. I say allegedly because I had no encounter with the perpetrator, and the victim was outside. She was waiting for her family to come, so I asked her to step over to the ambulance so I could chat with her and assess her. And she said he had hit her in the face. And this was not the first time that this situation had happened, but her house, he was living in the house. She needed to use the legal system in order to get him out of her house. That was going to take time. She was overcome with emotion, felt guilty, felt like the situation was her fault. So I listened. I didn't have a lot of questions to answer or even to ask. I just listened. I said, "Are you safe at this moment?" And she said, "Well, yes." I said, "What are we going to do to make you safer? Where else can you go? Your concerns are valid. You are in an abusive situation. This is intimate partner violence. So my first concern is to make sure that you are safe now. And my second concern is to make sure that you remain safe." And she was shocked. She said, "I never really thought about safety. I never really thought about an escape plan before." So I said, "Let's talk about a safety plan. If you need to leave your house in a hurry, where could you go?" And she said, "Well, I have a girlfriend that lives down the street." I said, "Good. Do you have her phone number programmed into your phone? Do you have a code word that you can call her and give her the code word so she knows that she needs to come and pick you up? Do you have children in the household? No. But if you did, where could you take your kids? How would you get there? Do you have transportation? Do you have pets?" And she said, "Yeah, I have a cat. I don't want to leave the cat here." And I said, "Well, do you have a cat carrier? And do you have a go bag of your cat food and litter stuff?" And she said, "Gosh, I never thought about that. I should probably go to the store and put together a go bag for the cat." I said, "Yep, you should have a go bag for yourself and a go bag for your pet. And how about your important documents? Your stuff, your vet records for your cat. Do you have some money put aside? Do you have your social security card and your driver's license and all of those important documents ready to go?" And she said, "You know what? I don't, but that wouldn't be hard for me to do." And I said, "Good. Those are all important pieces of a safety plan." And while I was talking with her, my partner was itching to go. He was like, "This is a dumb call. We don't really need to be here. There's a car crash down the street that we probably should go to." And I kind of said, like, back off because her issues are real. She deserves our time and attention. And at the end, she thanked me for spending time with her and giving her actionable things that she could do. So this safety plan discussion is the key. Safe place, plan for kids, plan for pets, transportation, items to take with you, so go bag, and support. Who is their support system? Who can they go to in their time of need?
Okay, so launching the last question. After
Yeah,
having learned about the elements of a safety plan discussion, would you be comfortable assisting someone in an IPV safe with an IPV safe?
I'm hopeful we're going to get 100% yes here, but I won't be too sad if we don't because hopefully I've at least made you think a little bit.
All right, I think we have all votes we're going to get. So just to share those results, we got 78% said yes and 22% said maybe, 0% said no.
I'll take it. Yay. Uh, I always feel like we got to talk a little bit about documentation because it's an important piece. So tell the victim that you want to document this and ask their permission to do so. Use the victim's words, not yours. If you do take pictures, be very careful. Document and label them appropriately. Person's name, location of injury, and name of the photographer if you're the one taking them. Document in the electronic medical record any health complaints, signs, symptoms that you notice. Measure and document injuries. When I say measure, I mean use a ruler. And when you're if you're going to take pictures, you put the ruler in the picture so you can actually measure the size of the bruises and that sort of thing. But don't document statements that the victim makes in the heat of the moment, those sort of like emotional sorts of things. Be very clear cut in your documentation. All right, back to our case study as we get to wrap up here. So Joy's husband says he's ready to start a family, but she says she's really uncertain about it. One day she can't find her birth control pills and she feels like, oh, I must have misplaced them. I must have left them there. One day she tries to reach him at work. He's supposed to be at work. She finds out that he isn't there. When he comes home, she confronts him and tells him that she is leaving. She is done being gaslit. And she's finally realized that this could be the end of the road for her. She's at risk. And her husband becomes violent and he punches a hole in the wall. So I do see there's a question. Let's wrap this up. Were there signs of IPV in this relationship? You guys called it. Early on, there absolutely were, but it was easy for the victim to kind of write it off. In this situation, is she now in immediate danger? Well, she calls law enforcement because she does feel like she is in immediate danger. And thankfully, one of the law enforcement officers takes her aside and he tells her, you are at risk. You need to make good choices here. Let's get the firearms out of the house. Let's get a order of protection filed, etc. And she begins the process of protecting herself. All right. We'll just do the summary and then we'll go back to the question. Remember, IPV is not just the physical piece. Survivors are likely to have job loss or reduction in work hours or need to take leave from their employment. So that's a stress on them and it's a stress on the system. They have concerns about housing stability, paying their expenses, and meeting their basic needs. So it's easy for us to say, just leave, but it's hard for them to do so. There's significant mental health issues and structural barriers associated with IPV. And oftentimes there's lack of social and economic resources and lack of access to care. And that makes the situation that much worse. So there's some new resources that are available as a result of digital technology. So digital therapy and digital service provision, and that is helping us with this IPV issue. Therapy virtually, therapy in a group, some of the app-based therapy programs, they're using telemedicine, so teletherapy, or just providing information or validating that seeing a therapist is safe. So those are some options for mental health support. And don't forget those validated screening tools. And these are all available in the handout. Maybe you didn't like the screening tool or didn't feel comfortable with the one I presented. Take a look at some of these others and find the one that will work best for you. And that leads us to the question. How do you handle the dynamic of talking to a female victim of IPV as a male, especially if you're taller and more physically imposing? That's a great question. So I think I would be careful about my seating position. I am very conscious about sitting when I'm talking with seated victims. So think about that power dynamic in terms of height and where you're sitting. Honestly, with vulnerable victims, please don't laugh. My partners will tell you and they will say, yes, we think Melody is nutty sometimes when she does this, but if I'm sitting with someone who's in a vulnerable position and they're sitting in a chair, I'll sit on the floor in front of them. So they're taller than I am, and they perceive that they're in control of the situation. Now, certainly I'm not going to do that if it's a risky situation where I need to exit from the situation quickly. But if I'm going to have a dialogue, I don't see any problem with sitting so that I'm shorter than the person that's talking. So that's number one. Number two, think about distance and think about physical space. And I would actually say it to the victim. I am a male. and I am clearly significantly larger than you are, that may be a trigger for you. So I just want to bring it up so that you know that I'm conscious and aware of it. And if I'm doing something or saying something that's making you uncomfortable, please tell me. Because once you've thrown it out there, it's no longer the elephant in the room. Great question. All right, so what happened with Joy? Law enforcement got involved. The law enforcement officer took her aside. She left. She had friends that took her in, so he didn't know where she was. She applied for a concealed carry firearms permit and enrolled in a personal protection course. She eventually felt empowered to take back her power, and she returned to her house, changed the locks, filed for a divorce, started over, and she is now an advocate for IPV education. So the end, there's a bunch of references there. I want to thank you for spending time with us today, and I greatly appreciate your time and attention.
Yeah, thank you so much, Melody, for discussing such an important and relevant topic today. And thank you everyone for joining us. Remember, you can visit us at careershare.com for more webinars and all other sorts of free resources. If you would like to earn free CE hours for attending live today, please complete the exam you will receive in your inbox in the next 48 hours. It will probably just be arriving today. Once you complete that, you'll receive a certificate and you'll be good to go. Thank you everyone again for connecting with us today, and thank you for all you do for your communities. Thank you and stay safe.